In CLL14, we have quite an extensive program on minimal residual disease, and it is one of the key secondary endpoints of this study. So the aim of the current analysis is, on the one hand, to better understand what happens with minimal residual disease while patients are on treatment, and what happens after they come off treatment with their minimal residual disease. So the first observation that we made and that we showed in the primary analysis 1 year ago was that the vast majority of patients who had received venetoclax obinutuzumab achieved a deep MRD negative remission. So over 70% of the patients at end of treatment had undetectable MRD values after venetoclax obinutuzumab, compared to approximately 35% in the chlorambucil obinutuzumab arm. So this was certainly confirmed, and we, in the current analysis, we on the one hand show that when we look at the half time of treatment, so after 6 cycles of venetoclax obinutuzumab, and compare this to the MRD status at the end of treatment, we observed that approximately 1/3 of the patients experienced a deepening of the response while they were on those 6 cycles of venetoclax monotherapy at the end of those 12 cycles, showing that it makes sense to use these 6 cycles of consolidating therapy because 1/3 of the patients benefit from it. And in addition, we also looked at different subgroups in that in this, and in addition, we also looked at the MRD levels after end of treatment. And there are various ways to do that. And given that we are measuring the MRD every few months in these patients, so between 3 to 6 months, we are continuing until today to follow up on these patients and measure the MRD values. And the problem is always that we do see there are a lot of changes depending on when the measurements were made and so on. And in order to break these down into one figure, we established a mathematical model that allowed us to calculate an individual patient-specific growth rate, a clonal growth rate based on a highly sensitive NGS assay that allowed us to really break down all of the measurements that we did after treatment to one figure that correlates at the end of the day with the growth rate of the patients when they are off treatment. And this is something that you can only do basically with NGS assays, because they are the only ones that really are able to quantify very sensitively very deep levels. So if you would just look at the standard blood count that we do in the daily routine, the lymphocyte counts would be, I don't know, 1 or 2,000 microliters per 1 or 2,000 lymphocytes per microliter. So they would be normal values, and we wouldn't see anything of the disease given the deep remissions in the vast majority. So we really need to look into with a very high resolution in order to detect these cells and thereby establish then the growth rates. And what we observed was, interestingly, that that there was not just a deeper remissions after venetoclax obinutuzumab in terms of the quantity of minimal residual disease, but also a different quality, given that there was a significantly lower clonal growth rate after venetoclax than chlorambucil obinutuzumab, and therefore the time until disease progression disproportionately was longer than with chlorambucil obinutuzumab and longer than one would expect, given when comparing the different growths between the two arms. So this shows that we also, by the BCL2 targeting, were able to somehow probably clear the bone marrow or the lymph nodes of more and various adverse clones than we can do with conventional chemomonotherapy, which again confirms how effective this treatment approach of fixed duration MRD eradication is actually. And at the end of the presentation and the abstract, we also had shown first data from the current follow-up analysis of CLL14. So we've reached now the median observation of approximately 50 months, and the 4-year PFS that we now that we are able to report now is 74% for venetoclax obinutuzumab, meaning that the vast majority of patients still, although they are off treatment now for more than 3 years, they still haven't relapsed, and that the vast majority still is responding or in remission. And in contrast, just over 35% of the patients in the chlorambucil obinutuzumab arm are still without PFS event. So the data overall confirm that this treatment strategy of fixed duration treatment is really feasible. And now with the longer follow-up, the data are more and more mature and ensuring us that it really makes sense to administer a treatment for just a certain amount of time and to deepen the remission within that period of time and allow for the patients to have and to benefit from a long treatment-free period.